Hey everyone, welcome to this USMLE Step 1 breakdown. If you're loving these high yield reviews, hit that like button and subscribe for more. Let's ace this exam together. Today we are diving into part 3 of our brainstem series, the Pons. This middleman of the brainstem is a Step 1 hotspot packed with cranial nerves and clinical gold. We will start with an overview. The pons sit between the midbrain above and medulla below, acting like a bridge. Literally, pons means bridge in Latin. We will explore its internal organization, think tracts and nuclei, then its anatomical neighbors, like the cerebellum and ventricles. Plus, we will tie it all to the clinical cases you will see on the exam. The pons is home to 4 cranial nerves and some key takeaways, so it's a prime target for localization questions. Get ready to connect anatomy to symptoms. A Step 1, love testing this stuff. Let's break it. So before we jump in, let's set our goals. This is your roadmap for mastering the pons for Step 1. First, we will get the big picture, an overview of the pons and its anatomical relations, where it sits and what's around it. Then we will zoom into its internal organizations, nuclei, tracts, the works. Next up, arterial supply. Knowing the blood flow is key for stroke syndromes. Finally, we will hit clinical correlations and high-yield cases. Think vignettes with cranial nerve deficits or motor issues. By the end, you will spot a pontine lesion in the question stem like a pro. This isn't just memorization. Step 1 wants you to apply this to the patients, so let's build that foundation and crush those neuro questions together. Alright, here we go. Let's meet the pons. It's the middle child of the brainstem, cradled between the midbrain and medulla oblongata. For Step 1, no. It's the origin of 4 cranial nerves. Number 5, trigeminal for facial sensations. Number 6, abducens for lateral eye movement. Number 7, the facial for expressions. And number 8, vestibulocochlear for hearing and balance. Here's your mnemonic tip. These all sprout from the pontine tegmentum, the dorsal part of the pons. That's the high yield fact. When a vignette mentions multiple cranial nerve deficits, think about pons. It also relays a station. It's also a relay station between the cerebellum and cortex, so it's busy with motor and sensory traffic. Localization is a key here. Pair those nerves with symptoms, and you're halfway to the answer. Let's keep rolling. Now let's map the pons neighborhood. Anatomy drives Step 1 questions. Anteriorly, we have got the prepontine cistern, where cranial nerve number 5 and 6 pops out. Posteriorly, it's snuggled up to the 4th ventricle, a CSF central. Laterally, the cerebellopontine angle is home to cranial nerve number 7 and number 8. Think about acoustic neuromas here. Superiorly, it flows into the midbrain. Inferiorly, it's the medulla. Now, beyond the 4 cranial nerves we covered, here's a memory trick. 4 medial structures all start with M. The corticospinal tract, motor pathway, motor nucleus of number 6, the abducens, medial lemniscus, which is somatosensory vibes, and medial longitudinal fasciculus, or MLF, syncing eye movements with cranial nerve number 3, 6, and 8. These M's are medial pons staples. Damage them and you have got a syndrome. Step 1 loves this. Know these M's. So now flip to the lateral pons. Step 1's got another mnemonic for you. 4 structures starting with S. First, sensory nuclei of the trigeminal, which has a facial sensation which lives there. Then the spinothalamic tract carrying pain and temperature. Lateral damage means contralateral loss. Next, spinocerebellar pathways. Unconscious proprioception for coordination. Think about ataxia if these fry. Finally, sympathetic pathways, autonomic fibers passing through. These S's are your lateral pons crew, and they are high yield for localizing lesions. Medial versus lateral matters. Medial hits motor and lemniscus. Lateral messes with sensation and cerebellum. Picture a vignette, facial numbness plus shaky limbs. Lateral pons. Step 1 tests this split, so lock in those S's alongside the M's from the last slide. Anatomies is your ticket to nailing these questions. Alright, so now let's talk about the blood, the pons lifeline, and a Step 1 must know. The basilar arteries' pontine branches are the main players, feeding the bulk of the pons. Up top, smaller chunks get blood from the anterior inferior cerebellar artery and superior cerebellar artery. Think upper pons corners. What about the venous drainage? It's a two-way street. The anterior pontomesencephalic vein drains superiorly into the basal vein, then the cerebral veins, while the inferior petrosal sinus takes blood inferiorly to the internal jugular veins. Why do you care about this? Strokes here, like medial pontine syndrome, tie to the basilar branch occlusion. Step 1 loves vascular questions. Which arteries is blocked if abducens fails? Basilar. Know the supply, predict the deficit. Blood flows, the backbone of the pontine clinical cases. Now let's see one in the next slide. Alright, now it is the time for a high-yield clinical case. Medial pontine syndrome, aka Foveal syndrome, named after a French physician and a step 1 star. This is a stroke smacking the medial caudal pons, caused by occlusion of the basilar artery's paramedian branches. The blood flow is cut and chaos ensues. Symptoms: weakness on one side, contralateral hemiparesis from corticospinal damage. Eye muscles paralysis. Think about cranial nerve number 6. So lateral gaze is flops. Horizontal gaze palsy, MLFs out. Facial palsy, cranial nerve number 7's nucleus or fibers are affected. Hearing loss, cranial nerve number 8's nearby. Facial pain or temperature drops, trigeminal sensory is hit, and vibration, touch, proprioception vanishes contralaterally. Medial lemniscus. This is a medial pons jackpot. Step 1 throws at you to test localizations. Know the basilar and those M's. Those are critical. Now let's wrap our Pons dive with medial pontine syndrome. Foveal's got some overlap with medial medullary syndrome, but the cranial nerves lineup is distinct, and step 1 loves the difference. Medial medullary hits number 12 and pyramids. Here it's Pons turf 5, 6, 7, and 8. Structures which are affected: corticospinal tract, contralateral weakness, abducens nucleus, ipsilateral gaze palsy. Facial nerve affected, ipsilateral facial droop. Trigeminal nerve is affected, which is sensory of course, facial numbness. Medial lemniscus, which causes the contralateral sensory loss. MLF is disrupted, horizontal eye movement fails. It's a medial pons party. Basilar paramedian occlusion triggers it. Compare this to lateral pons, which causes ataxia, spinothalamic loss. Next time for the exam, nail the nuclei and tracts. A vignette with gaze palsy and facial weakness screams Foveal. Master this and you're step 1 ready. Now let's further dive deeper into the medial pontine syndrome. On the lesion side, we have got ataxia of limbs and gait, more obvious if both sides are hit. Thanks to the pontine nuclei which relay to the cerebellum, you will see conjugate paresis towards the lesion. Eyes can't move that way, plus internuclear ophthalmoplegia, whereas the MLFs knocked out, disrupting eye coordination. Flip to the opposite side, paralysis of the face, arm, and leg from corticobulbar and corticospinal tract damage. Classic upper motor neuron signs. If the lesion creeps posteriorly, the medial lemniscus adds variable touch and proprioception loss contralaterally. Step 1 love this medial split. Gaze issues on one side, weakness on the other. Know your tracts and nuclei and you will ace those vignettes. Alright, so now let's shift our focus to the lateral pontine syndrome, aka Marie-Foix syndrome. It is a rare brain stem stroke hitting the lateral pons. This one's triggered by blockage in the anterior inferior cerebellar artery or ICA, sometime the basilar artery. It's a step 1 curveball, so know the symptoms tied to lateral structures. Picture this: facial weakness on one side, cranial nerve number 7's in trouble. Difficulty walking or moving limbs on that side. Cerebellar pathways falter. Vertigo spins the room. Hearing drops in one ear. Cranial nerve number 8's affected. Speech gets slurry. Swallowing is tough. Bulbar issues kick in. This is a lateral pons party. Multi-system chaos from one vascular hiccup. For the exam, localize it. ICA occlusion, lateral pons, cranial nerve, and cerebellar sign. It is a rare but high yield when it shows up, so master this. So let's dissect the lateral pontine syndrome further. Step 1 wants you to match structures to symptoms. First, the lateral spinothalamic tract, contralateral loss of pain and temperature from the trunk and limbs. Pain fiber cross early. Next, facial nucleus and nerve, a laundry list. Ipsilateral paralysis of upper and lower face, a lower motor neuron lesion, so there is no tears or spit. Lacrimation and salivation drops. Taste is gone from the front 2/3 of the tongue and the corneal reflex blinks out. Efferent limb down. Then principal sensory trigeminal nucleus and tract are affected, causing a ipsilateral facial hemianesthesia. All sensations is lost on that side. Vestibular nuclei and fibers, if they are affected, nystagmus, nausea, vomiting, vertigo. That means inner ear is screaming. Cochlear nuclei is affected. Ipsilateral central deafness. Hearing is toast. Step 1 tip. Lateral pons, ICA. Know this cluster. It will help you a lot. So continuing our lateral pontine breakdown, more step 1 goodies. The middle and inferior cerebellar peduncles also gets hit, which can cause ipsilateral limb and gait ataxia. Think about shaking arms and stumbling, since cerebellar input is fried. Then the descending sympathetic tract. This brings ipsilateral Horner syndrome, ptosis, meiosis, and anhidrosis, a droopy eye, dry small pupil eye on the lesion site. These tie back to ICA or basilar occlusion, disrupting lateral pons wiring. For the exam, picture a vignette: facial droop, deafness, ataxia, and Horners. Lateral pons screams at you. Compare it to the medial. Lateral's got cerebellar and sensory flair. Medial is motor heavy. Step 1 love these distinctions, so lock in the tracts, nuclei, and that ipsilateral contralateral dance. You're building a localization superpower here. So finally, we have reached to the superior cerebellar artery syndrome, SCA occlusion. It is a rare step 1 treat. The SCA feeds the cerebellar cortex, nuclei, and peduncle. So when it's blocked, chaos hits. What are the risk factors? Hypertension, cardiomyopathy or cardiopathy, hyperlipidemia, diabetes, smoking, oral contraceptive. Classic stroke triggers. The cause is often an embolism, which could be through the heart disease or atherosclerotic lesion, which send the clots flying. Symptoms are a grab bag: vertigo, dizziness, nystagmus, eyes flicker, limbs and gait ataxia, coordination is off, hearing loss. Since cranial nerve number 8 is nearby, there's also symptoms that includes nausea, vomiting, dysarthria, speech slurs. When it's Horner syndrome, sympathetics falters, contralateral sensory loss, spinothalamic crossed, ipsilateral tremor, cerebellar intent goes wild. Step 1 love this mix. Cerebellar signs plus brainstem extras. Localize it. SCA. Upper pons cerebellum junction. Know the risk and signs and you are vignette ready. That's our pontine and cerebellar rundown. Hope it's sharpened your step 1 game. Best wishes on your exam journey. You're going to crush it. If this has helped you, hit like and subscribe for more high yield content. See you next time.